Thank you, Dr. Shivam, and the esteemed panelists for the kind words of introduction. Good afternoon, everyone. I'm delighted to be here today to discuss about the newer concepts in the management of osteoporosis. As we all know that osteoporosis is a disease of bone, where we have decline in the bone mass, there is alteration in the microarchitecture, which leads to increase in the bone fragility, makes the bone more prone for fracture. And it is basically a major public health concern for postmenopausal women and elderly males. Traditionally, and in fact till date, we are managing osteoporosis with only one drug, that is bisphosphonates, with addition to the calcium and vitamin D. So why we need these new molecules? What is the concept behind this newer therapeutics? So we see that despite having compliance to the bisphosphonates, to the calcium and vitamin Ds, we see that there are history of recurrent fractures again and again. So to address these unmet needs, we need some better therapies which will have better efficacy with lesser side effects. So with this introduction, this is a slide which shows the first upper half, the traditional approach which we are following, and the lower half which shows the current treatment regime. So if we start with the bone resorption inhibitors, that is the anti-resorptive molecules, these drugs decreases or slows down the bone mass loss, but with slight improvement in the bone mass, but they do not improve the bone microarchitecture, and their action is very slow, that is over a period of 3 to 6 years. And then if we add the anabolic therapy, the bone microarchitecture which has been lost previously, it cannot be recovered, but the bone mass density can be preserved or can be improved a little bit if we add the anabolic therapy after the anti-resorptive therapy. So overall, in this approach, from anti-resorptive to the anabolic therapy, we are not able to improve the bone microarchitecture. On the other hand, the current treatment regime, it suggests, the studies have shown that if you start with the anabolic therapy, so this anabolic therapy, what does it do? It improves the bone mass, it also improves the microarchitecture over a period of 1 to 2 years. So it is rapidly acting, it improves the bone mass, and it also improves the bone microarchitecture. But as we cannot give the anabolic therapy for a long run, for about like after 1 or 2 years, we need to add anti-resorptive to preserve the bone mass which have been already added up by the anabolic therapy. So this treatment regime is better, where we first start with the anabolic therapy followed by the anti-resorptive therapy. So what are the novel agents in both these groups? First, the new osteoanabolic regime or new osteoanabolic therapy includes the sclerostin inhibitors, and then there are some newer drugs which can act on the DIPOF1 pathway, and the newer anti-resorptive drugs include the one which acts on the RANK ligands, cathepsin K inhibitors, and the SRC kinase inhibitor. So we'll discuss about these molecules in detail one by one. So let's first start with the osteoanabolic therapy, that is the anti-sclerostin antibody. So what is this sclerostin pathway? To understand the drug, how does it act, we need to understand what is the normal physiologic pathway. So this WND signaling pathway, as you can see in the basal condition, can I have the pointer here so that I can? So this is the WND protein pathway. In this signaling pathway, the WND binds to the LRP56 result co-receptor, and it prevents the phosphorylation of the beta-catenin. So once the beta-catenin remains unphosphorylated, its levels remains high in the cytoplasm, which further translocates in the nucleus and leads to increase in the gene expression. That is, it promotes the unphosphorylated beta-catenin, promotes the osteoblast or the bone formation. On the other hand, when the sclerostin binds to this WND signaling pathway, it inhibits the action of the WND and it inhibits the formation of the bone. So it increases the beta-catenin phosphorylation, and hence the further gene expression is inhibited. So if by some or the other way, if we can inhibit this sclerostin enzyme, if we can inhibit this sclerostin protein, we can probably stimulate the bone formation. So how this sclerostin is secreted? Under some mechanical unloading or under bone stress, in the presence of estrogen deficiency, osteocyte secretes this sclerostin protein And this sclerostin, it inhibits the differentiation of the stem cell to the osteoblast, and it also stimulates the rank ligand, which is a stimulus for increase in the osteoclastogenesis. And how the sclerostin is produced? It is a product of the SOC gene, which inhibits the osteoblastogenesis as discussed. And if there is some mutation in this gene, then it leads to increase in the osteoblast or increase in the bone formation, and this condition is called as Van Buchen disease, where there is increase in the sclerosis. And this mutation has also been seen in several kinds of skeletal dysplasia, and this forms the treatment target for osteoporosis. So, as I said, if we inhibit this sclerostin by some antibody, then we can promote the osteoblastogenesis. And we have this drug called romosozumab, which is available in the name of Evenity. It is a sclerostin inhibitor. It is a human monoclonal antibody, and it is used for a duration of about 1 year. And this indication remains for severe osteoporosis. So, if after 1 year of the sclerostin antibody use, if we want further anti-osteoporotic drug, then we need to switch to anti-resorptive therapy. The recommended dose is 200 mg. It is given subcutaneously once every month for 12 doses. It is administered by a healthcare provider along with the use of calcium and vitamin D supplementation during the treatment phase. It has received a black box warning that it is contraindicated in patients with a history of MI or any other cardiovascular disease within the past years. As it was seen in this ARCH trial, that this drug leads to increase in the cardiovascular events. However, in some other trials like FRAME trial, these events were not supported, but still it has received the black box warnings that it should not be used in patients who have got a history of cardiovascular events. There are some other safety concerns that it can cause hypocalcemia, it can cause osteonecrosis of jaw and AFF, that is atypical femur fracture. Now, the clinical studies have shown that even with a single dose, it can improve the bone densitometry at the level of spine as well as at the level of hip. As you can see here, these are the different doses of romosozumab given, and were compared to the placebo therapy, and to see that there was significant increase in the BMD at both the level of spine and at the level of hip at the different doses. And this was supported by improvement in the bone turnover markers. In the romosozumab group, there was increase in the bone formation marker, that is a P1NP, osteocalcin and BAL, and there was a decrease in the CDX, which is a bone resorption marker, compared to the placebo. Now, this is a very interesting data which shows the comparison between the romosozumab, alendronate and teriparatide. As you can see here, this green line demonstrates the romosozumab arm, and this orange one is a teriparatide arm, and this one is the alendronate arm. This is a placebo arm. So, if you can see that there is a significant increase in the BMD by around 11% in the romosozumab arm, while there was around 6% and 2% with teriparatide and alendronate in the level of spine. At the level of hip, again there is a significant increase in the BMD in the romosozumab arm. However, in the alendronate and teriparatide arm, there was a lesser increase in the BMD, while at the level of neck, the increase in the BMD was similar in both alendronate and teriparatide. So overall, we can see that there is a huge increase in the BMD with the use of romosozumab over alendronate and teriparatide. And this is because of the changes in the bone turnover marker. If you see clearly over here, with the use of romosozumab, there is certain increase in the P1NP, that is the bone formation marker, and as well as there is decrease in the bone resorption marker, and that's how romosozumab leads to increase in the aerial as well as the volumetric BMD. And if we see the bone turnover changes in the BTM by teriparatide, the increase in the bone formation marker starts rising after 3 months of the therapy, while with the romosozumab it is immediately after the start of the therapy. As well as with teriparatide, there is also increase in the bone resorption marker, and that's how the efficacy of the teriparatide is less compared to the romosozumab. And when we compare this alendronate, there is suppression of the bone resorption marker by alendronate, but there is also suppression of the bone formation marker, and that's how alendronate BMD improvement efficacy is less compared to the romosozumab. Now moving on to the second osteoanabolic therapy, that is the cellular activity, and hence there is lesser hypercalcemic response, and even there is lesser suppression of the bone, there is lesser stimulation of the bone resorption. So normally what teriparatide does, it improves the bone formation, it also enhances or also increases the bone resorption. On the other hand, abaloparatide, because of its shorter duration of action, it only improves the bone formation, and it does not enhances that much level of the bone resorption which is seen with the teriparatide. So this injection has to be given intermittently for around for 18 months, and it has shown that it stimulates the osteoblast and bone formation. So it is a daily again self-administered subcutaneous injection. The dose is 80 micrograms per day, and it leads to significant improvement in the vertebral spinal BMD. It has shown reduction in the vertebral fracture in comparison to the teriparatide. But importantly, it also shows greater non-vertebral fracture reduction, which is not there seen with the teriparatide. The safety profile is similar to teriparatide, in fact, lesser risk of hypocalcemia, and it is an FDA-approved agent for use in osteoporosis in postmenopausal women. And some steam patch versions are also available for short-term use. Now, again, this is a very important slide which compares the anabolic window of all these anabolic agents. As I was discussing, all these anabolic agents, how do they act? They increases the bone formation, but both abaloparatide and teriparatide, they also increases the bone resorption. But still there is a difference among this molecule. As you can see here, the teriparatide, the anabolic window is less compared to abaloparatide and romosozumab. So what are we looking at? What is this anabolic window? It is a time period where there is increase in the bone formation marker and there is less in the bone resorption. So lesser will be the increase in the bone resorption marker, more will be the anabolic window. So in the teriparatide, we can see that the bone formation marker along there is increase in the bone resorption marker simultaneously. So the anabolic window time period is less. However, in the abaloparatide, this bone resorption marker, the increase is less compared to the teriparatide. And in the romosozumab, as I already showed, with that P1NP graph, there is a rapid increase in the bone formation marker, and there is a suppression in the bone resorption marker. That is, the CTX levels was low with the romosozumab. So here again we get a 1 year full anabolic window. Now this is a summary of all the osteoanabolic agents which I was discussing. As you can see here, these all are available in the injectable form. There is with teriparatide, there is increase in the bone formation as well as increase in the bone resorption. Abaloparatide, same increase, but with the romosozumab, there is only increase in the bone formation and there is a decrease in the bone resorption. So this is very important. And this is the graph which compares the mean increment in the BMD with this 3 different agents. As you can see here, the mean increment in the BMD is highest with the romosozumab to the point of around 13 to 14% at the level of spine. At the level of hip, it is around 6 to 7%. While with teriparatide and abaloparatide, at the spine, the increment is almost same at around 8 to 10%. At the level of hip, it is around 3 to 4%. Now the next group of agent is the anti-resorptive therapy. So these are the target areas where we can target the anti-resorptive agents, which includes the rank ligand and this lysosomal enzyme, that is the cathepsin enzyme, and the third is the SRC kinase enzyme. So first start with the cathepsin key. So what are these cathepsins? Cathepsins are the group of lysosomal enzymes. They there are n number of cathepsin enzymes starting from A to Z. So these enzymes differ from each other in the form of their structure, their catalytic mechanism, and the kind of proteins they cleave. So here we are focusing to the cathepsin K, which belongs to this cysteine group of cathepsin enzyme. So how do they act in the very highly acidic medium in the osteoclast? There is increase in the secretion of cathepsins K by the lysosomes, and what do? They causes degradation of the collagen. So if we inhibit this cathepsin K activity, then we can inhibit the bone resorption. So what are the conditions which are associated with cathepsin K deficiency? It's pycnodystosis, which is characterized by short stature, increase in the bone mass with fragility. Even in the mice, it has shown that it leads to osteopetrosis, increase bone formation, and on the other hand, if there is overexpression of the cathepsin K, then it means that there is increased osteoclastogenesis, high bone turnover, further leading to osteopenia. So these are the so what the usual anti-disruptive does till date. So these bisphosphonate, they inhibits both the osteoclast viability as well as they are anti-resorptives, while the cathepsin K inhibitor, they are only anti-resorptives, they do not affect the osteoclast viability. So this is the difference between the usual or the classic anti-resorptives and the cathepsin K inhibitors. So there are three cathepsin K inhibitors. One is the odanacatic, which is given 50 mg weekly, and the other two are in the developmental phase. So today we will focus only on odanacatic. That too again not FDA approved. It is highly selective, non-basic inhibitor of cathepsin K. It is the most potent inhibitor of cathepsin K. The oral viability is higher than oral bisphosphonate. It is metabolized by cytochrome P450 enzyme and it do interact with other medications. Hence, some studies have shown that it leads to increased risk of CV events and hence it has not been FDA approved. So we need more cathepsin K inhibitor molecules which can provide better anti-resorptive therapy. In the phase 1 study, it has shown that dose-dependent suppression of CTX. The OCEAN study, which is a phase 2 study with this drug, shows that there is an increase in the spinal BMD by 5%, total hip by 4% compared to the placebo. In the LOFT study, which is a phase 3 study, it was stopped early because of the robust efficacy of the drug. There is a transient reduction of the bone formation marker also, and the adverse events like scleroderma-like lesions were seen, which were compared to the placebo arm. So this is how there is an improvement in the BMD with the use of this drug by around 2 to 3%. And again, it's a similar representation. Odanacatic is increasing the spinal BMD over 2 years by around 5 to 6%, and with the other drug, that is ONO, there is again 5 to 6% improving the spinal BMD. So cathepsin K inhibitors have got similar reduction in bone resorption markers with bisphosphonates. There is a lesser reduction in the bone formation marker than with bisphosphonates. And they have got rapid onset of action after stopping therapy, unlike bisphosphonates where we need a drug holiday and the drug keeps on acting for around 5 to 6 years even after stopping the drug. And no serious adverse events have been seen with odanacatic and ONO 534. Apart, few studies have shown that it leads to cardiovascular events. Now, another anti-resorptive agents which we are using is denosumab. It is again a fully human monoclonal antibody of IgG2 isotype. It is highly specific to the human rank ligand. It has got high affinity to rank, and giving this drug doesn't lead to formation of any neutralizing antibodies in the clinical trials. It has got T-half of 34 days and the recommended dose is 60 mg, which is given every 6 months subcutaneously. So how does it act? So in a normal physiological state, there is a balance is required with the rank ligand and the OPG ratio. So if any alteration happens in this ratio, then it can lead to increase in osteoporosis. So in conditions like postmenopausal women where there is estrogen deficiency, there is increase in the formation of rank ligand, and we know that rank ligand leads to osteoclast formation. It promotes bone resorption. So if we bind this or if we inhibit this rank ligand binding to its rank receptor, then probably we can inhibit the bone resorption. So this is the way it acts. Denosumab, it inhibits the rank ligand and hence it inhibits osteoclast formation and its function and survival. So denosumab again, it is an anti-resorptive agent and it also affects the osteoclast viability unlike the cathepsin K inhibitors. This I have already discussed. Again, denosumab has to be given along with calcium and vitamin D. It doesn't lead to any GI side effects like bisphosphonates. It can be safely given in patients with severe renal dysfunction, even with EGFR less than 30. On the other hand, bisphosphonates have got contraindication to be used with EGFR less than 30. So this is the area where denosumab has got an advantage over the bisphosphonate. Certain contraindications, it cannot be given with the patients who have got known etiology behind hypocalcemia like hypoparathyroidism, small bowel resection. It cannot be used in pregnant and lactating women. or in patients who have known to have hypersensitivity to denosumab. So this is the evolving landscape of the management of the osteoporosis. In the year 2003, there was teriparatide, and now we have moved on. We discussed the denosumab, romosozumab, and the latest one is the osteoporosis therapy. So basically, it is not a drug; it is a vibration therapy, where we give a high frequency, low magnitude vibration. It is shown to stimulate the bone formation, reduce the bone resorption, and even improves the blood circulation. So it is the latest one, 2024. It does not have any FDA box warning. The efficacy is less; it is only 5 to 10%. So probably the combination of all those therapies we should use in our practice to have a complete osteoporotic management. So to conclude, combination of new drugs will improve the efficacy and adherence, but at a higher cost. Osteoanabolic agents have got quicker action and they are more effective in improving the bone mass compared to the oral bisphosphonates. But do remember, osteoanabolic drugs have to be stopped after 1 or 2 years of therapy, because later on that anabolic window periods vanishes and then they have to be followed by anti-resorptive therapy. In cases of severe osteoporosis with multiple fractures with t-score of less than -3, and so in those group of patients, we can even start with a combination therapy of both anti-resorptive as well as osteoanabolic therapies. Now this cathepsin K inhibitors, they are a newer class of agents, so we need more research, we need more drugs in this area. So to end, don't wait for the fracture, act before the crash. Thank you.